Welcome to Medicine Redefined. I'm Dr. Altamash Raja.
And I'm Dr. Darsh Shah. Let's put the health back in healthcare.
Before we dive into today's conversation, I have an exciting update. My new practice, Refining Health and Performance, is officially launching soon. It's a practice built around health, longevity, and performance, the Medicine 3.0 approach we talk about every week here on this podcast. And here's the best part. It's a telemedicine clinic, so you can work with me from the comfort of your home. Our founding member enrollment is now live, so if you'd like to learn more or join the waitlist, visit refininghealthrx.com. All right, let's get into the episode.
We're back here with part two. For all the listeners that don't know and are coming here new to this episode, we did a part one here with Dr. Allison Grimaldi about the hip. So please check out part one. You'll get a really good foundation about hip anatomy and some of the terminology. And obviously in part one, when we were talking, we were overly ambitious. We had so many things to try to get through that we just couldn't. We ran out of time. So here we are back with part two. Dr. Grimaldi, can we start with FAI, Femoral Acetabular Impingement? Can you help us define what that is and what that really means?
Sure. So femoral acetabular impingement is really just impingement of the head-neck junction of the femur against the acetabulum earlier in range than would be typical. And so that's usually associated with a couple of different types of bone shapes. And the most common and the most problematic seems to be cam morphology, which is basically an aspherical femoral head where we have a little bit more of a bump at that head-neck junction. And so that can become a problem as the hip comes into flexion and internal rotation, and we get early impingement of that bump against the acetabular rim. Then we have another type of impingement that's called pincer impingement, and that's associated with either a deep socket or a retroverted socket. And so that also can lead to early impingement, or we can have a mixed type FAI where we have both the cam and the pincer together. But if we go further into that definition, so FAI is really just a structural thing that we're talking about. If we're talking about pain associated with that, then we'd usually use the term femoral acetabular impingement syndrome. And that was something that was recommended in the Warwick Agreement in 2016 when they suggested that clinically relevant morphologies that predisposed to FAI should be referred to as femoral acetabular impingement syndrome, and that requires a triad of symptoms, which is usually groin pain, clinical signs, which is usually painful restriction of hip flexion, internal rotation, that impingement type position, and imaging findings. And so imaging findings, either finding a cam, so an aspherical femoral head, which has variable sort of definitions in the literature, but I usually use an alpha angle of more than 60 degrees, which just measures, that bump at the head neck junction, or having that sort of over coverage anteriorly of the acetabulum, or a mix of those. But it's important when we talk about FAI that we're talking, particularly if we're looking at interventions, that it's the symptoms that make it something that we will intervene with in treatment. And so it's having those three things: the symptoms, the clinical signs, and the imaging findings.
When you talk about alpha angle, are you looking primarily on MRI or are you looking at on CT?
Well, the largest data set that we have from the Czech cohort was actually just done on AP X-ray. So we put a circle around the femoral head and then, line down bisecting the femoral neck. And then we put a line where that femoral head first leaves that circle. And that shows us how much asphericity we have. But certainly if we're looking for that 3D shape of the head neck junction, either CT or MRI will give you more information. And with MRI, they can do specific sequences where they sort of measure all the way around the head neck junction, because with AP X-ray, of course, we're really only getting a good view of that anterolateral sort of area, that lateral anterolateral bump. And more recent research has actually shown that in females, that bump is more commonly going to be anteriorly rather than anterolaterally or anterior superiorly. And so that means if we're only looking on a pure AP, you might miss that sort of cam morphology, particularly in females. So I guess if we want to be really clear about that shape, something like CT or MRI is a good way to go because we get more 3D information there.
Do you have a sense of when the first reported case was? Is this early 2000s or late 90s?
Yeah, I think early 2000s. I can't give you an answer on what was the first paper that sort of talked about it. But as with anything, it takes quite a while for that information to start trickling into clinical practice and what does it mean for clinicians, and then further research, So that Warwick Agreement was 2016, but that paper was published because there'd been like an explosion of information and papers around looking at the shape of that head neck junction particularly, and there was some belief early on in our journey there with FAI that if you had a bump, it's always going to lead to arthritis, so we need to go and do surgery even if there's no symptoms. And that was certainly something that potentially became a problem because we had patients who were asymptomatic and then became symptomatic and had very poor outcomes from surgeries that were just based on let's operate on an image. And so that's why it was great when the Warwick Agreement came out that said, right, we shouldn't be operating on people unless they have FAI syndrome, and we're looking at changing symptoms rather than just looking at morphology.
Yeah, I asked that question because I see people probably in their 40s and 50s, and they're like, I've never even heard of this. And at this point, it's progressed into osteoarthritis. And, that's a sequelae of untreated disease. And they'll mention, well, how come, I've had this issue? How come nobody said anything? And, one argument somebody can make is, well, the prevalence of FAI or FAI syndrome has been increasing. But then we also recognize that, well, that's not necessarily true because this is a problem that we've only started talking about really heavily over the last 10 years, maybe last 5 years, I'd say. So that's the classic spotlight effect, right? If you're looking for something, you're going to tend to find it. And so I tell them, oftentimes we didn't even recognize this. But I think there's also the other side to that in terms of development of FAI syndrome. And, my understanding is in terms of just early sports specialization and early activity in the adolescent years. So what can you tell us about the development of the disease? At what point throughout the life cycle are people more predisposed to that? Are there certain positions, sports, et cetera?
Sure. So with primary FAI, so we can have secondary FAI that might develop, associated with osteoarthritis and development of osteophytes and things like that. But primary FAI is really something that develops during adolescence. And the evidence so far suggests that high volume activity and particular types of activity. So high volume, we're talking, more than 4 training or game sort of sessions a week, and particular types of activity seem to predispose to this bone shape as well. And they generally tend to be what we refer to as hip heavy sports, which are generally weight bearing, change of direction type sports. So it's interesting, the dramatic difference in prevalence, for example, in ice hockey compared to downhill skiing. So it's that particular combination of flexion rotation, perhaps with body weight forward a little bit, which will really sort of increase that load across the hip joint and, the use of those muscles, creating compressive load or stimulus across that epiphysis in the head of the femur. So any sort of field sports, court sports, change of direction type sports, but at that high volume. So we know that those things, are risk factors for the development of the condition. And then, the change usually occurs during that peak height velocity, so in that early adolescence. Now, there's some studies that have shown even cartilaginous changes, as early as 9, 10, 11 years of age. Generally, the bony changes we start seeing, between 13 and 16. And, for males that might, progress, through, 16, 17. So males tend to, the growth plates close a little bit later. And so we might see those changes still progressing into that age bracket. Females, our growth plates close a little bit earlier, so 13 to 15. So 15 usually, those growth plates are closing. And so the theory is at the moment that those types of loads, particularly flexion rotation loads, create some stimulus in the epiphysis, and the epiphyseal, the lateral extension of the epiphysis starts to occur. And so instead of being like a semicircular arc between the head and the neck, at that sort of supralateral aspect most commonly, that epiphyseal line starts to sort of change direction and head down the neck a little bit. And that seems to create some change in where the bone grows. So we start getting this outward growth at that head-neck junction. There's another theory as well that what we might be getting is some early closure of the posterior aspect of the epiphysis. And so it ends up, ballooning at the front because we're closing early at the back. And that has been linked with those heavy loads across the back of the hip joint there. But it's one of those things that we still probably need to understand more about the condition and the development of it.
Can you explain what the epiphysis is?
Yep, so the epiphysis is just the growth plate. And so the head of the femur in a growing child is a bit like an ice cream cone. So we've sort of got the neck with, the head sort of sitting on it, and we've got this line between the head and the cone, if you like, and the neck. And it's a line where growth occurs, and that's, how our long bones sort of grow.
Got it. Now, I was curious about weightlifting. I think that's one sport that we've been talking now about getting it introduced earlier to athletes. Younger kids are now starting with that. Now, especially with the squat, right? This is when I feel that pain in the groin. If I'm doing a Bulgarian split squat and I'm slightly internally rotated, I'll get that little pinch in the groin. But how does weightlifting progress to this? Does that load actually increase the bone density and then cause this type of pain? Or is it that if you're practicing at a younger age, you can get more of a range of motion that actually makes you more comfortable in these positions?
We don't have good evidence around weightlifting specifically, and it's certainly a topic that there's been lots of discussion about in terms of safety of weightlifting in, our children and adolescents. I think it's just in terms of safety of, weights in adolescence, it's just, looking at the overall volume and intensity of that weightlifting and then what ranges that they're getting into. And I think it's something that we do need to monitor each individual and be mindful of their range of motion, because we're not going to be imaging our adolescents every year to see, do you have a cam morphology developing? But in Australia, anyway, we see a lot of young athletes, sort of males and females, now being put into weightlifting associated with sports, rugby, soccer, but particularly sort of the rugby sort of football codes will often see that going into some heavier, sort of more formalized gym training. And that might include not just squats, but things like, for example, a incline leg press. Now, an incline leg press, you basically start at 90 degrees of hip flexion, and then you have a weight pushing your knee to your chest. So I've certainly seen some, mid-adolescent, more commonly I've seen it in males, but injure their labrum quite significantly by being put into weight training and perhaps not having been screened adequately in terms of, what is their range of motion? What is the healthy range of motion for this individual? Because if they've already got a cam in place, and then we start loading them with heavy weights into ranges that are pushing them to their physiological end of range, we might increase the risk of, pushing them from a asymptomatic bony morphology to something that is painful. In terms of the role of weightlifting in development of these bony changes, again, as I said, we don't have evidence for that, but I do think that we need to be mindful during periods of peak height velocity, like the additive loads that our young athletes are being exposed to. And if we know they're in a period of peak height velocity, peak height sort of change, we probably need to be looking at modifying loads that might be hip heavy loads, and that might include the type of gym work that they're doing as well during that period.
Yeah, I think to steal a quote from Eric Cressy, he always talks about assess, don't guess. And, I don't remember us starting high school football training or even in middle school when you came in as a freshman, I guess at 13 years of age, and getting any type of screening to see what your hip mobility was. I remember there was a point when my coach told me that, lower body is certainly more important for football, Dr. Grimaldi, and I was doing the leg press 3 times a week, Monday, Wednesday, Friday, because, more is always better. So, yeah, and here I am today. Now, I don't know if you know this, but both Darsh and I, we're osteopaths, right? And one of the tenets of osteopathy are that structure and functional are interrelated. And really what that means is, what your structure is, it's going to affect how you function, and then vice versa. Now, some of my surgical colleagues will say, well, you really need to address the structure, because if you have that overgrowth, over coverage with the pincer lesion, or you've got the overgrowth with the cam, well, you're not going to have optimal function. And, I remember reading a paper last year, actually, one of my orthopedic surgeon cousins had sent this to me as he was trying to convince me to get surgery, that this was published maybe in 2024 over at HSS, where I think the title goes something to the effect of modern day hip arthroscopy can help prevent osteoarthritis or reduce the risk of progression to osteoarthritis. And that's a really contested, hot topic nowadays, where you have to address the disease early on. I put that in quotes, or you are going to potentially, or if you don't, you can't alter the course of the disease, and they're going to get to early arthritis, and they're going to have further consequences downstream, lifelong pain, et cetera, et cetera. What are your thoughts on this?
Sure. So there's a couple of considerations there. So first, what are the links with bony morphology, pain, and the development of osteoarthritis? There's quite variability in the research in terms of the relationship between morphology and pain. And then the development of osteoarthritis, there is some good evidence that a cam morphology will increase the risk of development of osteoarthritis. But if we look at, again, that earlier Czech cohort research that looked at shape and the development of OA, we're only talking sort of, up to 25% on the research that's available of people with cam morphology that will actually go on to develop osteoarthritis, within a 5 to 20 year sort of period. Although a lot of the research we've got available still at the moment is on a 45-year plus, age group. So we don't have enough evidence yet on the younger population. In terms of pincer morphology, again, from that Czech cohort research, they didn't find actually a link between pincer morphology and the development of osteoarthritis. Actually, they showed a slight protectiveness having that pincer related to the development of osteoarthritis. So that link between pincer and OA is still a little bit unclear, perhaps, but everyone agrees that cam morphology is the morphology that seems to be potentially more problematic for the development of pain and osteoarthritis.
Let me jump real quick. What are your thoughts about pincer being somewhat protective, to use your words? What might be happening there?
Well, I guess if we compare like pincer to dysplasia, for example, so if you've got more weight-bearing surface compared to less weight-bearing surface, we know acetabular dysplasia, where you have a shallow acetabulum or less weight-bearing surface, more microinstability, then that's been clearly linked to the development of early osteoarthritis. Having a deeper socket, which potentially may have more stability and more weight-bearing surface, maybe that's what makes it less problematic. I'm not saying there's definitely no links, but what we have from that large check cohort, which was over 1,000 people, they weren't able to establish that link. So it does question the rationale for rim trimming procedures as a joint preservation procedure. But there is clear evidence, as I said, for CAM, and Renti Agricola's more recent paper from that cohort then put the imaging findings together with clinical signs and showed that if you had symptoms and restriction of range, so 25 degrees or less of internal rotation, so if you had painful limitation of range and CAM morphology, then that significantly increases your risk of development of OA. So I think it was like a 7-fold increase or something like that. So I think that's why the FAIS is an important thing when we're sort of looking at, preventing, OA. Do we just, go off an intervention based on imaging? No, it needs to be the signs and the symptoms as well. But to come back to your question about what evidence do we have for prevention, from a surgical side of things. From the surgical side of things, I think the paper you're referring to, that was a paper that was a retrospective paper, I believe. And so they compared a group that had had arthroscopy and had the, procedures to try to osteoplasties to reduce the bony impingement, and then compared to a group that they gathered that had basically had not had conservative treatment, so non-surgical treatment. And then they came out with the conclusion that those that had had surgery had less risk of developing osteoarthritis, but there was no difference between the groups in if they were likely to go on and have a total hip replacement. But we have to look at the biases in the study. One, it was retrospective, and if we looked at the conservative group, they were patients necessarily who had had an index image, so they'd had some imaging done, when they first reported their pain, and then they'd had another image done at some time in the future. And so when I read that, I went, okay, so we're pretty much self-selecting people that had ongoing symptoms, because if they hadn't had another image, they'd probably done well, settled down. And so we're basically saying if we compare people who have ongoing symptoms that haven't been able to recover with usual care, whatever care that they had, we don't have information on that, then they might be at slightly higher risk of developing osteoarthritis. But again, retrospective has a high risk of bias, and that paper did, clearly sort of call that out. So the only we really need prospective studies to be able to determine if surgery can prevent osteoarthritis. The only study that I'm aware of at the moment that has done high quality prospective research in RCT environment is the FATE study by Palmer and colleagues. And so they recently published their longer term data, which was 38 months. So again, it's not that long a period of time, but still there was, enough time for there to be changes in that joint space width. They compared again a surgical group to a rehab group that had just had physiotherapy-led treatment. And what they found was that there was no difference between the groups in terms of change in that joint space width. And so their conclusion at the end there was that from the data that's available, there's not strong evidence that arthroscopic surgery, including osteoplasty, can prevent the development of the disease. And so the surgery should be really more targeted at, are we going to help with pain and function rather than are we actually going to prevent osteoarthritis? And that's from the data that we have available at the moment. And it's very hard to do that research, of course, because even that paper that was, high quality, well done. But if we look at the loss to follow-up at that 38 months, I think there was like 50% loss to follow-up, for those who came back and did that imaging again at that point of time, which of course, anything more than a 20% loss to follow-up introduces significant bias. And so it's hard to do those studies and keep track of those people for a long period of time. But they did, a good job at giving that a good shot in the FATE study.
How do you personally determine who's a good candidate for surgery? So I know you highlighted what the evidence suggests with FAI syndrome, pain, CAM, somebody might be a better candidate with outcomes, potentially a younger person, better healing. We'll exclude all the other factors like smoking and risk of diabetes and that kind of stuff, frailty, nutrition, et cetera. When you're looking at movement quality, joint loading, biomechanics control, how are you assessing or advising somebody that maybe surgery is in their best interest?
Well, I think we don't have a good answer to that question at the moment, like an evidence-based answer, if you like, and that is probably one of the the things that research and clinicians are really trying to determine who is the patient that will benefit from early surgery. We don't know that at the moment, but we know that the larger the CAM, the more risk you have of developing, significant pathology and osteoarthritis in your hip. So perhaps those with a larger CAM are more likely to be, a better surgical candidate. Perhaps those who have those more concerning chondral injuries where we actually get delamination of the rim cartilage, and that's something that perhaps needs to be addressed earlier surgically. But the tricky thing with that is that it's often not easy to determine that on imaging all the time. In terms of a clinical approach to who needs surgery, I would always suggest that we did a trial of non-surgical care first. And the evidence that we have for non-surgical care still at the moment is still building for that conservative care, but we need to have, like, for example, the trials, the RCTs that have compared physiotherapist-led intervention versus surgery have really only allowed like 5 to 6 treatments, over a relatively short period of time. For someone with FAI, often they will get benefit from, more treatments or treatments over a longer period of time with that. And I think we can make good changes in a lot of our patients with load management, so helping them understand their condition and trying to reduce exposure to those positions of impingement. And particularly I reinforce to my patients it's exposure to repetitive, sustained, loaded or rapid movements into those positions of impingement. And so we can do a lot of training and education on, right, let's move through this range. This is a hip happy range for you. So we're happy for you to continue your strength training, and it's important to keep strong, but we're just going to, limit the range that you go into so that it's an appropriate range for you. Getting patients to really monitor their own symptoms. So I think inflammation, as we know, is a really important an important driver for the development of degenerative change in the hip joint. And so that load management piece is really important, managing activity levels generally, and then, managing what they're doing in their exercise therapy or in their gym work as well, so that we can keep that hip as calm as possible. So if they've got ongoing symptoms, and that's the big thing. If you get them stronger, if you get them functioning better, and when I say functioning better, that they're really able to control that pelvic position, because a lot of the people that we're talking about who are going to surgery might be involved in, again, weight-bearing activity, change of direction sports. You're landing on one leg, and often when we're looking at them moving, we're seeing that when they land on one leg, they're dropping into positions of adduction and internal rotation. So the pelvis starts dropping towards that weight-bearing leg as they're moving into a flexed hip position. So they've sort of got these patterns of uncontrolled dynamic impingement. So that's something that we try to work on. But if we've improved that, we've improved their strength, they're adequately load managing, as much as they can within the constraints of what they need to do functionally, and they're still having symptoms, then that might be a time where they really need a surgical consult.
What about, let's shift gears. So you've had a young person who's had arthroscopy, we'll say both the labor's been repaired, you've had the osteoplasty, they've shaved down some of that cam, and it wasn't excessive. And they've gone through the earlier phases of rehab. So I want to kind of pick up when we can really start getting aggressive with exercise. And I'm more interested in actually the long-term consequences, because one of the things I learned as I was speaking more to my colleagues across the pond, other parts of the world, is we do a bad job with expectation management in the US. And I can make some arguments and why I think, with respect to our business model and incentives and why we might be doing that. I think that's the case with the procedures in general. But it was really interesting, I think, when I came to your workshop over in the UK, when I was talking to everybody else, and it was well understood that really at 12 months out post-arthroscopy, it's okay. It's totally normal not to have symptoms. What was interesting is my conversations prior to that with people over here on this side, a lot of expectations were, a lot of discussions with surgical colleagues, even maybe some sports non-surgical colleagues, saying, 6 to 8 months, you'll be good. You'll be returning to sport, performing at a high level. And when you actually dig into the literature and you talk to people, you learn that, return to play, return to performance are two very different things. And lingering symptoms are actually quite high for a lot of people. So I want to get a sense of how you approach those patients. I mean, if you could talk about how you set expectations for patients post-arthroscopy in terms of timelines, and like, how do you progress them through that, if that pain never truly resolves, like you were talking about?
Yeah, and I think that's something that's really important. And it's really interesting looking at the literature on expectations, in that patients have really high expectations of surgery. They have really low expectations of physiotherapy or rehabilitation. So, and I think part of that is because this is sort of perceived as such a structural thing, that patients tend to believe that it's very unlikely that they're going to be able to get an outcome without surgery, because they have this structural issue that needs to be fixed. And I do think there's a really important role from, both the medical side and rehab professionals as well, leading into surgery, to set up those realistic expectations of what to expect after surgery. Because I know that patients that I see are usually going into that surgery after seeing the surgeon believing that their hip is going to be fixed after surgery, and they'll be able to get back to running, within 10 to 12 weeks, and then they should be fine in 6 months. But the reality is, exactly as you've said, what we're talking about is the literature certainly shows improvements in pain and function for a significant proportion of people who have that surgery. And so we can give patients that information, but will their hip be cured? Will they have a pain-free, full functioning hip back to sport? That takes a significant period of time, and not everyone will get there. And so we're talking about, like, if 100% is, full pain-free hip, what we're seeing is that patients on average might go from 50% pre-op to, say, 70%, post-op, but they're not usually at that 100%. So it takes a lot of, rehab and effort and training to sort of get back to those higher level sports. And some people, and certainly not everyone, will be able to achieve that for various reasons, and that might be the state of pathology that was discovered when the surgeon went in. We know that if you've already got degenerative change, the outcomes of that arthroscopy are going to be poorer afterwards. The other thing that I think is important is, again, that role of inflammation and effusion. And there was a paper last year by Wang and colleagues, and it was really interesting because they tracked synovitis effusion in patients who'd had arthroscopic surgery for FAIS. And they showed that actually effusion in the joint peaked at 3 months. So it was more than pre-op at 3 months after surgery. And by 12 months, 60% of patients still had significant effusion within their joint. And that was linked with poorer outcomes. And so I think it's important that patients sort of understand that they still, even after surgery, they have to learn to manage their hip and control inflammation and do the work, do the rehab, and not push too hard too fast, because that's more likely to, result in, delayed outcomes and poorer outcomes because of that role of inflammation and effusion. And then, of course, post-op, we can get other complications that might be related to adhesions in the joint after surgery, which is just, part of what happens in a healing process, particularly if we don't have good early movement after surgery. We can have microinstability of the hip after surgery, particularly if the capsule hasn't been repaired. And that might be, a reason for ongoing symptoms afterwards. So it's quite a complex interplay of, structural issues, inflammation, what they're doing with their hip, how much rehab they're doing in terms of seeing what sort of outcomes we're going to get in the shorter and long term.
Whose job is it to have that expectation management conversation, you think? Is it the surgeon's job? Is it prehab?
Well, in an ideal world, it would be that we're all giving the same message. And what we see from a physiotherapy perspective is we're often giving different messages. So the surgeons perhaps not, I don't think necessarily misleading the patient, but perhaps not having enough time to discuss, those expectations in more detail. So from a rehab perspective, and we have a little bit more time to perhaps discuss what to expect afterwards. And rehab professionals are also the ones that are living that with the patient afterwards. So it is important for us to set those expectations early. But I think setting those expectations preoperatively is important, because that is really important for informed decision making. And so in an ideal world, we're all informing them, they're getting consistent messaging, and they're going into it being really, eyes wide open, understanding that this is not going to be, it's fixed because that bit of bone's been trimmed off. It's still going to be work and rehab for a significant period of time after this surgery.
What about the joint that looks quote unquote perfect on imaging? You got the x-ray, you got the MRI, there's no labral pathology, no impingement of any sort, yet they still have pain, and it's presenting as true classic hip pain. Mm-hmm. How do you approach that person?
Mm-hmm. Sure. So we're talking about completely normal morphology, so no dysplasia, no FAI. And so then we're thinking about, well, if we think about what are the sources of nociception, the sources of pain within the hip joint. So labral tear is one of the most common capsular labral structures. The synovial lining is highly innervated. The ligamentum teres is certainly highly innervated, and that can be a source of symptoms. And so those are the potential sources. And then, of course, we have like the cartilage itself. We don't really feel in the cartilage. It doesn't have sense receptors in, a normal cartilage, but subchondral bone. So we have to consider bone as well in like a endurance athlete with low BMI or someone with, bone density issues. So, but outside of bone, if we've got normal bony structure, and we're sort of considering, right, well, we do think that there's something inside the hip that is painful. Why is it painful? So usually it's associated with something that they're doing in terms of their overall loading. So are they, loading their hip in a way that's really pushing it towards its physiological limits? So sort of working at extremes of range of motion, even without bony morphology that predisposes to early impingement. Any hip can actually reach a position of impingement if we put it far enough through range. And so if we're doing things like ballet, gymnastics, martial arts, circus performing, those sorts of things where they're moving to end of range repetitively or sustained, rapid, loaded, particularly with poor control around the hip, poor muscular control, then that might predispose to the development of symptoms over time. Having reduced capsulolabral support of that hip joint. So if we've got someone who has laxity of that capsule and ligaments, so that might be just their natural state. So they might be on that hypermobile end of the spectrum or have some sort of collagen disorder, or they might have focal capsular laxity just related to overloading that capsule. So for example, a throwing athlete who's repetitively, like a baseball pitcher, for example, repetitively pitching, that back leg is going to be repetitively pushing into extension external rotation, which overloads the anterior capsule. And particularly if they're really forcing into that end of range, perhaps without adequate muscular control at the front of that hip joint, then that might sort of lead to some issues. So microinstability is one of the conditions that we suspect might be a problem in those people that don't have clear bony issues but have this pain, and particularly those who are on that mobile end of the spectrum. So it's usually what they're doing with their hip and then other risk factors that they might have.
Awesome. Well, that's a perfect transition to kind of going into the next lane, right? So you mentioned dysplasia, hypermobility, microinstability, right? So if we stick down that lane, can you just give us, when you're seeing a patient like that, truly the clinical signs that those patients present with, and maybe at what age are they really coming?
Okay, so microinstability, we haven't been very good at picking them up, but we're starting to get there. And so there was a nice criteria that was published by Vikas Kanduja and colleagues in 2023, which published the microinstability diagnostic criteria, which is the first attempt at trying to get some criterion around, right, what do these patients look like? How can we actually diagnose them? Is it just someone who stands on one leg and they're a bit wobbly? That's probably not adequate for a diagnosis of microinstability. So that paper suggests that, again, like with the FAI agreement, that we need to have a combination of symptoms, clinical signs, and imaging findings, or if they've had surgery, intraoperative findings. But in people who haven't had surgery, then we're sort of looking at imaging, clinical signs, and symptoms. So it tends to be, hip pain. If that stability issue is anterior, then they'll tend to have that sort of mid-inguinal pain or C-sign type pain around that hip joint. With dysplasia, we certainly can see that pain, around, that whole hip, even into the deep buttock, even sort of some back pain on the unilateral side with dysplasia. And that is most commonly or most probably linked with the iliopsoas and the psoas having to work so hard to try to support the joint. And so with dysplasia, we tend to see signs of iliopsoas-related pain and abductor-related pain as well, because those muscles are working so hard to try to stabilize the hip joint. But unfortunately, that means that a lot of people with microinstability or, even sort of bordering on, macroinstability, if you like, being diagnosed with hip flexor-related pain for way too long because they've got this, persistent pain at the front of their hip. And so I always suggest that if you've got particularly a young female that is, persistently returning, complaining of mid-inguinal pain or hip joint sort of pain, it's like, well, that mid-inguinal pain, it's unlikely to be iliopsoas, like particularly if there's no injury mechanism that you can find for those hip flexors. And so that's usually a bit of a reflection that the soft tissues are struggling because there's something happening underneath. So if we've got persistent soft tissue signs, we really need to consider what's happening in that underlying joint. And so the other thing that might make you think instability will be like symptoms of giving way or lack of confidence in their limb, particularly in weight bearing rotation, and feeling like their hip's going to give way. Sometimes they'll complain of their leg feeling heavy when they're lifting it in and out of the car, or lifting it, when they're lying on their back. So those sort of symptoms of giving way, feelings of instability. Sometimes there might be, clicks, snaps, pops, those sorts of things that we commonly see in people with more mobile hips. If they have a known sort of history or family history of, dysplasia, of course, clicky hips, or a family history or their own known history of some sort of collagen disorder. So if they've got, if they tend to be hypermobile. And then clinically, we tend to see that this population will often have, higher ranges of motion. So very different to the presentation of FAI in that, well, the same in that they'll both be positive on an impingement test when we take them into flexion, adduction, internal rotation. But the difference being that FAI, they'll have this, hard bony block and limited range of motion. With those with dysplasia or instability, we tend to see more larger ranges of motion. But I do want to just flag there that the FAI and instability are not necessarily two completely separate things. And more now we're realizing that those with FAI can also have microinstability. And there's some nice fluoroscopic data looking at people with FAI with cam morphology just walking, so not actually pushing their hip to that impingement zone, so just walking, and that had shown, larger gapping between the head of the femur and the acetabulum, and aberrant movements of the femoral head in the acetabulum, even in sub-impingement zones. And so there's a lot more discussion now about that concurrence of FAI and instability as well. So all that means is they're not necessarily going to have huge ranges of motion, so we can't rule out microinstability and FAI as well. Yeah, and then we've got tests that we can do, clinical tests for stability for various different areas of the hip. So the apprehension test, the log roll test is commonly used, but there's a variety of other tests that we can do as well. And then, imaging needs to be assessed for, signs of dysplasia, the big things that we're looking for there.
And for that, you're looking at the lateral center edge angle?
Yeah, so there are multiple different ways that we can look at that. But yeah, so the basic imaging things that we're looking for is, lateral center edge angle. So we have under coverage of the femoral head by the acetabulum. And then the other main one is like the orientation of the acetabulum, so the upward orientation. So if you've got a roof angle or an acetabular index sort of more than 10 degrees, then we're going to get more of that sort of migration of the femoral head, or translation of the femoral head in the acetabulum. The fear index was also sort of noted in the microinstability guide, but there's lots of different ways that we can actually look at the structure of the hip joint and things that might also impact on stability, things like even the femoral side of things, so the neck shaft angle. So if we've got a more vertical neck, that might, predispose. If we've got significant femoral anteversion, so the twist in the femur, that's more likely to predispose to anterior instability particularly. Even looking at the sphericity of the femoral head, we're sort of used to looking at the femoral head that is aspherical, that it pushes outside the circle. But actually you can have a femoral head that dips inside the circle at that head-neck junction, and that's referred to as the cliff sign. And that population who, doesn't have that nice round head, actually they're a bit skinny at that head-neck junction. As they come up into positions of hip flexion and rotation, they actually may lose that vacuum suction because they don't have enough bone. So the stability of the hip joint is that congruence of the head of the femur and the acetabulum is so critical for the stability and that vacuum in the hip joint. So there's femoral side of things also. So there can be a number of things. And so I think we need to make sure that we're not just relying on the lateral center edge angle for that determination.
Yeah. What's unique about the rehab approach here as opposed to more the impingement stuff that we were talking about earlier?
Sure. So for this population, getting that, I think there's two really key pieces. One is good function of the capsular muscles, so the muscles that join onto the capsule, so the iliocapsularis and the iliacus not joining onto the capsule, but very important as a sling across the front of that hip as we move into hip extension. The gluteus minimus joining into that superior, anterior, superior capsule, and then the deep external rotators, obturator internus and gemelli, and obturator externus that join into that capsule posteriorly and posterior inferiorly. So that cuff of muscles for this population becomes really, really important, particularly if you've got a floppy capsule, floppy ligaments, if you like, then those muscles are going to need to do more work and be more efficient at maintaining the capsular tension through ranges of motion. And so we use a lot of real-time ultrasound to look at those muscles and to optimize that early recruitment in those muscles, because what we often see in people with hip pain when we're visualizing this with ultrasound is we're seeing a delay in the recruitment of some of those capsular stabilizers. So people with no pain and normal function, when they go to move their hip, the first thing that we tend to see on ultrasound is that deep muscles recruit first, and then the superficial muscles come on to provide that force, that torque production for movement. But that early recruitment of the capsular stabilizers is important for joint protection, because we pre-tension that capsule and help center the head of the femur, but potentially also just from an efficiency point of view, we want those capsular stabilizers working to center the head of the femur so that when your big force producers come in, you're not getting all the energy lost around the hip because the hip's wobbling around. So both from joint protection point of view and from an efficiency point of view, we want that early recruitment of those capsular stabilizers. And we often see deficits in that. So that's something that I do think is important in that population. And then the other piece that's important, so across both groups, strength is going to be important. And actually across both groups, then pelvic control is incredibly important. But if you've got dysplasia or impingement, at both ends of that spectrum, it's important, but we'll be focusing on slightly different things. But with that microinstability or that poor control, and if you've got dysplasia, you've got less weight-bearing surface, and so the labrum will take more load naturally. So in someone with dysplasia, the labrum, goes from taking 1 to 2% of your body weight to 4 to 11% of your body weight. So it's naturally taking more body weight. But if you are weight-bearing in a way that overloads those rim structures, then you're much more likely to have symptoms. So for example, if the patient is functioning in relative posterior pelvic tilt, so if their pelvis is rotated back, so that will reduce the anterior coverage of the head of the femur by the acetabulum. And so we'll have less acetabular coverage that will put more load on the edge of the acetabulum. Now, surgeons talk a lot about edge loading, with hip replacement and things like that. But in the native hip, that edge loading is also really important. So making sure that people get that control, getting that acetabulum over the head of the femur. So that pelvic control piece is incredibly important. And then we need to do graduated sort of, strengthening, making sure they're controlling that. But I think that the two key things there is that good deep muscle function, and then good pelvic control, and then graduated sort of strengthening and functional loading.
Right. That inside out approach that you
Yeah.
speak about. What are some go-to exercises that you like to start with that you've found in your experience that are better to get some of the recruitment for the deeper muscles?
Sure. So we would usually start with some isometrics for each of those deep muscle groups. And so that would be taught as a preparation for movement. And so for the hip flexors, for example, we might be lying on the back with a couple of pillows underneath the knees, and the patient is just preparing to lift their knee, but they're not actually going to lift their knee. And so they keep the more superficial musculature relaxed, particularly TFL, sartorius rectum, and they just prepare to lift their leg, and they should feel a deep tension sort of in that mid-inguinal region for that iliacus iliocapsularis. For the external rotators and abductors, there's various different positions that we can do that in. But for example, you could do side lying with a couple of pillows between the thighs so that we're sort of neutral abduction rotation. They can do a preparation for lift into abduction, and again keeping that TFL relaxed and just working on that slow, gentle recruitment into abduction. For the external rotators, we work on just a little heel push, like an ankle push down into the pillow in that position. But other things I like, for example, for the hip flexors, even just practicing something like pelvic tilting is really nice in like a high sitting position, for example. So sitting on a high plinth or a table or something like that, and just working on slowly bringing the pelvis into anterior pelvic tilt and back to neutral position without moving the chest. So we don't want that happening sort of through the thoracolumbar erector spinae. But we've looked at this with ultrasound, and we get really nice recruitment of iliacus and iliocapsularis actually doing that nice little pelvic tilt. And that sort of is a bit of a win-win, because we're also teaching them to get your acetabulum over the head of the femur, particularly in that population that tends to be more posterior pelvic tilted sway type population, where they stand with their pelvis sort of out the front, their pelvis translated anteriorly to the base of support. And so this gets nice recruitment in those deep hip flexors while they sort of work on that motor control of controlling the pelvis over the femur as well.
It's funny you said that, and I could see that Darsh was doing his pelvic control while he's seated and I'm standing, and I did it simultaneously. What about cars? Earlier this morning, I was on LinkedIn, and actually, believe it or not, one of your Aussie colleagues, he was a physiotherapist. I just saw somebody talk about the piriformis and then gemella. And I clicked on it because, everybody wants to blame the piriformis for everything, but nobody ever talks about some of the other short external rotators. So I figured I'd check this video out just because he gave the superior inferior gemella a little shout out. And he was just talking about how cars are going to be the fix to stiff hips, so to speak. I actually haven't heard where you stand on that. I know it's really getting to a lot of end ranges, but there is a lot of motor control there. So what are your thoughts on that specific exercise?
Cars.
The controlled articular rotations. So I guess if I was to describe it, really, you could do this with really any joint. And actually, Darsh, why don't you describe it? Because I know you did that DNS thing, right, with this?
Yeah, cars is just, so if you do like a 90-90 with the hips, and it's really isolating just the hip joint and trying to make all your other muscles static and all your other joints static while you are taking, let's say, the hip from internal to external rotation. So I'm trying to actively do it right now over the camera. But yeah, it's a really just controlled articulation of the hip joint. I think that's where most people, I think that's the most favorable joint that I've at least heard from, people doing cars. People will try it with their shoulders too, and really just have a controlled articulation from, one range of motion to the other. So I don't know.
Yeah. So if I was to describe it for the hip, right? So let's just say we did it in a standing position. You probably wouldn't start that. You would have somebody come up into full active hip flexion as high as they possibly could. Then you would take it all the way out to external rotation as far as you possibly could. Then you would do deep internal rotation and then extension, and then bring it back to neutral. And then you would reverse that motion. Mm-hmm. Seems like that's not something you've used routinely.
I know. I thought you were actually talking about a vehicle. All right. So there is value in the concept of controlled, smooth, rotary sort of training, but yeah, you won't be able to, if you're doing a full range, active range of motion, you're not going to isolate that to the deeper capsular muscles, if you like. Yep. So you're going to use all muscles around the hip, but you're just going to use them in a controlled way. And so really it's just a motor control exercise. But if you have dysfunction already, I'm not convinced that that alone is going to, solve your dysfunction. And one of the things that I see is particularly open chain exercise. If we're trying to deal with dysfunction and imbalance, if you like, between some of those superficial muscles or muscles like your TFL, sartorius, and, your glutes, for example, and those deep rotators, I find that you are much better off having your foot in contact with the ground. So as soon as your foot is off the ground, you tend to seem to get a lot more recruitment or upregulation through that anterolateral corner musculature. And it's not like there's any exercises that, a muscle, this muscle will turn off completely and this muscle would be doing all the work. It's not like that anywhere around the body, but around the hip included. So it's not like we can do a completely isolated exercise for one muscle or one part of one muscle. But the principle of slow controlled rotation is good. In that flexion rotation position, I guess you just have to be careful in terms of if they have rim pathology and you're sort of rotating, at that range of motion, is that provocative for the patient? So maybe just considering the range of motion. But yeah, there's no one easy answer to this is the best exercise and this is bad and this is good. So there's different elements that are likely to be useful, and for some patients, particularly who already have dysfunction, perhaps not as useful in certain exercise, types. But we don't have enough evidence for the moment in terms of what is the best exercise for, X, Y, or Z. But slow controlled rotation, I agree, is not a bad idea. But wherever you can, get your foot on the ground when you're starting to talk about those. After we've done that early isometric phase, I would generally do weight-bearing exercise, weight-bearing control training, and we can do that slow control of pelvis on femur, but in a weight-bearing situation where you'll tend to get a lot more stimulus of those deep rotators and glutes relatively to that anterolateral hip. So I think, go with the exercise that you think makes sense with what you're trying to achieve, but make sure then that what you're trying to achieve is actually what you're achieving. So ask the patient where they're feeling it, put your hands on, we have the benefit of being able to use ultrasound as well to sort of check what's happening in some of those deeper muscle groups as well. And that does make it tricky for the hip because, you can't easily sort of palpate any of those different muscles. So a lot of it is a leap of faith. We're hoping that what we're doing is, what we're trying to achieve. But at least we can, have a feel of what's happening in the superficial system.
I'm tempted to ask you about the clamshell, but I know I'm not going to take you there. I think people, if they want to get your thoughts on that, then we'll plug some other podcasts that you've spoken about that at length before. Let's make a somewhat hard turn here. Maybe not too hard that we get dizzy, but we talked a lot about on our first discussion with respect to tendon health. And, I think we just think about pain in general. As you highlighted so eloquently earlier on, this is a syndrome, right? And it's not just structure we're looking in isolation. You have a variety of factors you're looking at. One of the things that we're starting to appreciate is the role of metabolic health, hormones, and just homeostasis of the individual and how that plays a role in tendon healing, tendon pathology to begin with, and perhaps even pain. I recognize just from following some of your work, this is something that you've been talking about a little bit more as well. So how do you, first of all, evaluate that in part of your assessment processes? And then, what strategy are you using to implement, to have discussions with that stuff in terms of getting better outcomes?
Yep, sure. And I do think it's incredibly important. And I think there are, areas that, certainly rehab professionals, I know from a medical perspective, you're probably much more likely to perhaps go, and look at those and discuss those more global factors. I think from a rehab perspective, if we're seeing the patient as first contact practitioners, we need to be monitoring and taking a look at these factors and referring on for additional assistance where required with those factors. Metabolic factors for some individuals, I think, will be incredibly important. And so we're looking for the person who is, higher BMI, hyperlipidemia, diabetes. So those factors have been linked with tendinopathy, but not just with tendinopathy, with joint conditions as well. We need to consider that global systemic inflammation. Now with tendinopathy now, we recognise that we rarely see a true inflammatory process, an acute inflammatory process in the tendon, but systemic inflammation may certainly be involved. And we see with tendinopathy higher presence of, TNF alpha and interleukins and things like that. So we need to consider that more global inflammation piece. And so, tracking, BMI, so asking patients, their weight, looking at their BMI. For gluteal tendinopathy, carrying weight around the hips, around the middle, seems to be linked with that risk of gluteal tendinopathy as well. So those are things that I think we need to have a discussion about and not be perhaps afraid to have that discussion as rehab professionals, because carrying extra weight will have both a physical effect when you're standing on one leg for gluteal tendinopathy, for example, but then we have the metabolic effects as well. So doing a good history, asking about general health, asking weight or weighing the patient themselves, looking for that gynoid adiposity around the middle. And then, if we think that's, if they're sort of flagged as having some risk factors there, it's something that I think we should start talking about earlier than we do. Because if they start getting onto that early together with their education and exercise program, they may get there a little bit more quickly or have better outcomes. Again, we don't have the evidence for that at the moment, but it makes sense from a clinical point of view. And like diet will feed into that as well. So nutrition will feed into that in terms of that systemic inflammation as well. And so pairing those two things together, like strictly sort of, reducing the intake of sugars and high GI carbs will be really important. Trying to sort of minimize processed foods, takeaway foods, things like that. So good, healthy, green leafy vegetables and, your good fats in your fish and things like that. So there's that nutritional piece, but that might require, referral on to, a dietitian or a nutritionist to feed into that. If there are other issues involved in weight, that might involve a multidisciplinary team, that might involve, even an endocrinologist, depending on what's happening with that weight, a psychologist, if there's a psychological sort of element to that weight. And so I think those factors are really important. And then we have, the hormonal piece. And certainly for tendons like gluteal tendinopathy, we know that the prevalence is so much higher in postmenopausal females. So hormones seem to have a role there. Estrogen is important in the health of the collagen tissue. So when we start losing estrogen, then we're more likely to see these tendon conditions come out. And that's something that we should be really mindful of and be able to educate patients about, even in the first instance, in normalizing or helping them understand that, we often see a lot of postmenopausal women who are very distressed because they might have multiple sort of areas of pain. So, gluteal tendinopathy, maybe some plantar fascia, maybe a little bit of, shoulder or elbow symptoms. They'll feel like their world is falling apart, their body is falling apart. They'll usually end up seeing a rheumatologist because it looks like a systemic illness. The bloods don't support a systemic illness, but there's something happening systemically. And, hormones are, a big player in that. And I think there's still huge under recognition of the role of hormones and interventions for hormones. And I think we've been through just at least a decade or more of females being and general practitioners being really fearful of prescribing hormone therapy for postmenopausal women because of one poorly executed and poorly interpreted study. And so we need to move past that and start giving females, assistance from that hormonal perspective as well.
Yeah. Yeah, I definitely appreciate you bringing up all the lifestyle factors, right? I mean, they all go hand in hand when it comes to metabolic health. And, recently I've just been finding the conversation around the world about metabolic health, I find stops prematurely just when we talk about weight. And then what does that weight lead to? Okay, we know ill health, but explaining actual disease processes, right, affecting the joints of the hip, the plantar fasciitis, or whatever it might be, whatever organ system you might want to pick. So I think that's an important discussion that needs to be had a little bit more. When you work with high performing athletes, let's say, right, somebody who has all these lifestyle factors dialed in, however, let's say they're aging, we'll take a 60-year-old triathlete, for example. What are the type of discussions you're having with that type of patient when it comes to maybe risk benefits, still trying to perform and achieve whatever their goals might be in whatever sport they're having, but also knowing that their body, has taken on a lot of quote unquote beating throughout the years through just the different types of movement patterns that they've been going through?
Sure. And I think there it's about, throughout the ages, I'm always very proactive in terms of trying to get our patients not reliant on us. So they need to be self-monitoring their own bodies and understanding when they've pushed too hard. So monitoring response, not just during exercise, but that night, how they're feeling that night, next day, making sure they're attending to recovery. It takes us a little bit longer, to recover potentially. And then the other thing is really just about natural sarcopenia that is more likely to occur with age, and the need to ensure that there is adequate strength training, resistance training, being incorporated. So a lot of triathletes and runners, for example, aren't doing enough strength training. And particularly when we're sort of, entering those older age groups, that's going to become even more important. So strength training to maintain adequate bone density and muscle strength. And with that, being able to maintain metabolism, because metabolism starts to reduce as we age. And part of that is associated with the sarcopenia, the loss of muscle bulk. And so we need to make sure that our older athletes, but all of our older population understand that what they need to do to maintain weight and maintain health as they age is to make sure they're including some strength training. So for our endurance athletes, often they go, no, I'm just going to run. I prefer to run or cycle or swim. But that's not necessarily going to be adequate to maintain muscle size and metabolism. And so I think that's incredibly important. And for females, particularly postmenopausal, strength training is incredibly important for maintaining, health of their bones and their muscles and their tendons. And so I think the way athletes train may have to slightly change as we age, and a little bit more attention into resistance training, a little bit more attention into recovery, looking after their body as well, listening to their body.
Yeah, I love it. I think that's the biggest thing as well. I mean, you've touched on this a couple of times in terms of identifying what works for you. And that's what makes it so challenging. I think it's funny for me, I had at least a thought that I understood the hip really well until I took a couple of your courses. And it's the saying goes, the further you get out from the shore, the deeper the water. And you start to realize that how complex this really is, right? When we're talking about the twist in the femur, you're talking about the variety of different factors that we have to look at. And there is a tremendous amount of overlap, right? That lucky person that you said who might have instability and impingement simultaneously, like that, they've really hit the lottery. And how do you help that person? At the same time, I'm overwhelmed when we have these conversations and when I learn more about the hip, but I'm also super excited because we've learned so much just in the last decade. I was diagnosed in 2016. So, just coming up on 10 years, I remember at the time surgeons saying, hey, listen, hold off as long as you can because hip arthroscopy, it's its infancy and you don't want to do that right now. And mean, you would know it better than I, but I tell people like it's probably in the toddlerhood now is what I would say. Probably not much more than that. But the future is really bright because we're having these conversations. You present at some of these meetings worldwide, your colleagues with surgeons, some of the world's experts. So my question for you is, given all that you know, all that you're learning, and you seem to be the person who's learning every single day, what are you most excited about with the future of hip and pelvic pain care? And maybe we'll keep it focused to over the next 5 to 10 years. I'd love to know what technologies you're looking at, innovations, diagnostics. What are you excited about?
Sure. Well, I'm excited at the moment that we, like surgeons and rehab professionals, we're definitely coming closer and starting to talk more of the same language, which is fantastic. So 20 years ago, talking about instability of the hip joints that really wasn't a thing, outside of trauma or frank dysplasia, instability was not accepted, but we were, from a rehab perspective, we thought, well, it probably, makes sense. But it was interesting in the last ISHA conference I went to, the Hip Preservation Society conference in Washington last year, there was so much conversation around instability and the relationship of instability and impingement. And there was much more discussion from a surgical medical perspective about pelvic position and even movement and posture. And it was incredibly exciting because it's like, yay, we're finally talking the same language and understanding that it's more than just a single bone shape. It's a complex issue that we're dealing with all of these hip conditions. So that's particularly exciting for me. And I actually love going to the arthroscopy conferences because our surgical colleagues are actually doing a great job with taking up the reins in trying to really understand these conditions. I think we still need to go broader, but at least there's a lot of research that's happening, which is exciting, and we're understanding more every day, which is great. In terms of technologies, I think we need to, the big black box, I suppose, certainly in the rehab world, is still being able to identify, measure, and adequately show changes in movement. At the moment, it's sort of like a bit of a dark art. It's something that, we look at with our eyes and sure, we can take a camera and we can measure some measures, but it's not highly sort of, accurate. But there's some technology that is coming out of Brisbane here that I've been involved in some feedback with that technology. They call it Smarty Shorts. So I'm a bit excited. This is Laura Diamond's project, and they're basically like bike pants with sort of accelerometers in them. And they're developing like an app that you'll get real-time feedback of how you're moving and joint loads. And so the long-term look at that is understanding how people are loading and giving them immediate sort of biofeedback on how they're moving so that we try to change that movement and see if that, helps with their joint symptoms. There's still a long way to go there, but I think we definitely need better ways. And I've played with lots of different technologies trying to see if we can measure, and the pelvis and the hip is incredibly difficult to measure movement. And so that's one technology that I'm excited about. And I think there'll be other technologies that will get better and better, hopefully, but accelerometer technology, but things that are wireless and that are much more practical for use in the clinic or even as a biofeedback tool outside the clinic. I think that's exciting. We've still got a long way to go with, matching the, movement patterns and, whether that's going to be problematic or not. And I guess that sort of goes to the other thing that I think is where we're heading towards in individualized care. So really sort of understanding what's their body shape, how are they loading their hip, and it's something that I teach a lot. We don't want to just throw someone on a bed and do some clinical tests. We want to understand how they're loading, how they're moving, and where's the area of pain, what structures are being overloaded, and understanding, what mechanical factors might be contributing to that. But then, as we've just talked about, looking at the pieces around hormones, nutrition, metabolic health, and trying to bring that together in a very individualized treatment package for the person. And I think that's when we really going to start getting some good traction with some of these presentations that have just got, persistent pain that we're probably not getting quite on top of.
Love it. A lot to look forward to. I'm still shocked that most of this hip development is like from the early 2000s, and then you guys are all talking about toddlerhood and infancy. I mean, I was squatting 10 years ago, and I'm like, this hurts. This must have been like found out way, way before. So this is all new to me, and it's crazy because, I mean, this Altamash for us, like cam, pincer, these are all just like the words that we have to learn, even though I'm not in sports medicine, but for our board exam and all. So I feel like to most of us, it's kind of things that we thought were, established. But to speak along the lines of timelines, what is something that you've changed your mind on, let's say in the last 5-10 years in regards to the hip and everything that you've learned?
What have I changed my mind about? Well, I guess, FAI is one of the interesting things. Like when we first started talking about FAI, the physio approach to FAI at that time was, okay, we've got restricted hip flexion, we're impinging at the front. So what we want to do is stretch out the back of the hip so that we can try to give them greater range of motion. We now understand that it's not such a great idea because those who have impingement anteriorly are at risk of actually posterior instability and even subluxation or dislocation at the back of that hip joint. And do we even want to give them higher range of motion? Certainly, if it's a bony block, we don't want to try to increase range of motion for FAI, because if we do manage to get that cam deeper into the acetabulum, what are we going to do? We're actually going to create more shear force and more damage around a larger rim of cartilage. And so I think that's been a significant shift in the terms of when we first, were talking about FAI and what we would do from a rehab perspective, and we are very, perhaps, rehab professionals are often very impairments focused, and like restriction of range of motion is an impairment, right? So let's try to, restore that range of motion. We now understand that, you've got a bony limit, and that's what it is. And so we have to give them education around looking after your hip. This is your hip. It doesn't like going into that range, so we're going to have to modify that. So I guess certainly there's been shifts in understanding around that sort of mechanical side of things. And then the other shift for me, I suppose, is just, more and more that metabolic hormonal, dietary aspect that previously, rehab professionals probably, have put, oh, well, that's not my role. I'll just sort of leave that over to the side there. But I think more and more now we need to become more holistic and, certainly, bringing other health professionals in for multidisciplinary care where required, but at least being more mindful of those. So I guess that's a couple of examples of changes that I've seen.
Awesome. Well, Alison, thank you so much. Again, I've said this time and time again, I'm a big fan. I've learned a lot from you, not just in these conversations, but also offline in our conversations and attending some of your workshops. I've plugged them multiple times, so I'll plug them again here. I think that when it comes to elevating, my knowledge to learn more about the hip, and not just the hip, but just movement and pelvic anatomy and the complexity of that and how to actually implement that practically, bring it back to our patients, that's been very helpful. In fact, your masterclass paper that I highlighted last time, I made that required reading for a lot of my mentees that I work with respect to lateral hip pain. So thank you for everything that you've done. I know you're flying all over the place. I see you coming up in Hong Kong, New Zealand, you got conferences. So where, other than dralissongrimaldi.com, where else can people find you? Where can they connect with you? What's a good place for them to reach out?
Great. Yeah, my website is probably the best place to find, and there's heaps of free content on there in the blogs. There's lots of sort of detail in the blogs there. Then I have individual courses that people can do, or they can join our HIP Academy. So for HIP lovers or HIP learners, and you can really dive into the detail in HIP Academy. And we do live meetings and masterclasses, case studies, Q&A sort of sessions in the HIP Academy, as well as just access to a heap of video and quick reference PDF downloads and things like that. So that's probably the best place, and there's a contact form there. But I'm also on all of the main social media channels, so either at Allison Grimaldi or at Dr. Allison Grimaldi. You'll find me on most of those social media channels.
Excellent. We'll put all that in the show notes. Any other parting words of wisdom, Alison, for the hip learners or hip lovers or anybody with hip pain?
I think know your anatomy around the hip. That really helps. That's a really good starting place for assessing and managing hip conditions. And be a detective. I think our role is very much asking questions, and sometimes we're so excited or perhaps time poor, and we're sort of heading straight to those clinical tests. But what you get from your patient interview is so incredibly important that don't skip that part. Ask those extra questions because you just get so much great information there that will help direct your diagnostic process, but also direct your management process as well. So don't rush that patient interview. Be the detective, ask lots of questions, and you'll reap the rewards.
Amazing. Last question, Alison, that we ask all of our guests. Now, I don't know about the healthcare system down under, but here it's much more of a sick care system. And so we always like to ask our guests is, how do we put the health back in healthcare?
How do we put the health back in healthcare? Yeah. Well, I think we've talked a lot about that today, haven't we? And I think putting the patient at the centre is really critical there, and asking patients about, their goals and what they want to achieve. And so moving away from very much an impairments-based model of just the clinician looking for impairments and looking at, and trying to see how are we going to fix these impairments. We really need to be looking at what the patient wants to do, what's their goal, and really tailoring our treatment to get them back to full health. But full health is for the individual. We need to understand what full health looks like for that individual.
I love it. Dr. Allison Grimaldi, thank you so much.
Perfect. Thanks very much.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We also want to thank our team for the production of this podcast, specifically Ethan Ju on video, Haritha Yepuri on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. Also, if you enjoyed the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.